several questions for you guys. So we are going to ask you some of these questions. But bottom line is, you all have demonstrated that with the minimally invasive way, you can do a nice, lymph node dissection for in these cases who have and require groin dissection. It not only serves for purpose of diagnostic, therapeutic, or prognostic value for these patients. And if you look into the literature, there are a couple of randomized controlled trial. Even the lymph node yield was more than with the minimal invasive procedure than the open procedure. All right, so let me come back to the question. So I would be asking question to Dr. Rawal and Dr. Tarun Jindal. So there are a few questions from the audience. They were asking regarding how to create the space. You did demonstrate, but if you want to re-emphasize, that is one. And second question was, did you come across any injury to the femoral vessels? Because sometimes they are aberrant or if they're stuck in those areas. And third question was lymph node yield. I mean, you all presented, but they were asking about that. And fourth question is utilization of fourth arm when you are using a multi-port exercise system.
Space we have already demonstrated. Both of us, we use same technique when we go from lateral or from, from below femoral triangle apical approach, which we say. I remember in the beginning, we were using only finger and that finger will be used to create the space and docking the port also, making a space for port on the finger. I'll put the incision, then put a port. And then rest of the resection will be with the robot. But later on, we switched over to putting a balloon with a suction or anything, and that works very well. Second question that did we come across any type of femoral vessel injury? Not so far, but in one case there was a small artery which somehow bled in post-op, which was sutured later on, but not a major vascular injury so far. We have done hundreds, more than hundreds. Yield of lymph node is equal to the open, and many series they say maybe more, but we have removed around 27 lymph nodes also, if you see our paper in Journal of Urology, and we don't feel that we do the compromise outcome when we do the robotic veil. If the lymph node is stuck to the vessel, then it's probably not to select such case for the surgery. But if suppose you have started and later on you have come to know, that can be dissected off the vessel easily. But most of the time, this is an extranodal disease. And in node-positive groin, there's a selective group of the patients who should be offered this type of surgery, because problem with the high pressure is that cancer cell, they fly, and there is a theoretical problem. Theoretically, one can say that the patient will have local recurrence, a bad local recurrence, which has not happened in our cases. We have done in node positive groin also. There was a question of size of the lymph nodes. Generally, we prefer to use robotic veil in the patients who have lymph node of 2 centimeter or less. Very rarely 2.5, but not in 3 centimeter at all. We will definitely go for open surgery. Tarun, you can tell your experience.
Correct, sir. So I agree with the size. So our upper limit is 2 centimeters. See, if you're doing for a 3 or 3.5 centimeter, you have to cut open and you have to give a larger incision. So that takes away the advantage of a minimally invasive. Plus, to handle these nodes, I mean, you would end up rupturing or damaging these nodes in that cavity. So the point of having an oncological clearance will be subdued. So I would strictly say that stick to 1.5 to 2 centimeter as your upper limit for oncological safety. As far as the lymph node yield is concerned, so yes, lymph node yield, my highest probably would have been around 34 on one side and 32 on the other side in the same patient. But lymph node yields are never an issue. We have never faced low lymph nodal clearances by the virtue of doing a veil. As far as there was another question about using the fourth arm. So no, there is no need for fourth arm at all. The fourth arm is Nemo. So the gas itself raises the flap up, and the entire the adventitial tissue opens up because of the gas seeping into it. So you don't require a third arm at all. So, and the space, sir, is already very well defined. So you just need to identify the glistening fascia, which is the deep fascia. So keep on dissecting bluntly. Once you find that deep fascia, put your finger, make some space, put in a balloon, you will see that the entire space has opened up. So that balloon we tend to say around 250 to 300 cc, and that gives you enough space to dock your arms. I think these are the questions.
The one comment I would like to make, sir. I have done a robotic whale using SI robot, X robot, and XI, all three. And then we were actually changing the position of robot from the groin wise when we were doing the technique, which conventional technique. But later on, we were doing from one side only using SI robot. So these things are doable from one side, and you know, you can innovate your docking position as Tarun has already done. But my one question is from Dr. Ahmed, that when he uses single port, does he feel the limitation of movement in comparison?
So that's a great question. That is the when you first start to use the single port coming from the XI, it does feel that way. Absolutely. It feels like your hands are tied behind your back and you're working with your left hand. But once you start to spend a little bit of time and understand the how the machine works, then you get used to it. I mean, right now, a lot of time I sit down, I feel like I'm using an XI, although I'm using single port, but initially it does feel very restricted. But once you learn the formation and conformation, how the angulation of the camera and the instrument, then it does get a lot better. And it allows you to work in a very small space, bit at a time.
The question for all these speakers, any incidents of DVT in these cases, pulmonary embolism and surgical emphysema? And one quick question to Ahmed, you know, did you do any of cases with the retrograde technique? Because this is all antegrade approach, but did you do antegrade approach? Suppose you want to do a one side.
So my initial couple of cases I did the retrograde approach, you know, each side. Okay. But definitely, if you do one side, then you could do, you know, your comfortable way or your familiar way. But I think, you know, the way I'm doing it, you know, I'm just doing it new, and I'm not going to say I'm the expert on this.
Oh no, I know.
Yeah, but I think you know, the surgeon who does a lot of these inguinal and lymph node dissection, I'm sure they can come up with even a better way of doing it, integrate with the single port robot, you know, because they have much more familiarities and they can do it much more efficiently. It's just getting that machine and learning that technique of using it.
Right. Any episode of, so the other question is, any recurrence at the surgical site? So where you place the port, any recurrence of the cancer in the long-term follow-up in these cases?
Not so far, sir. But I'm sure if you choose your cases carefully, the local recurrence or recurrence at the support site will not occur. It will only occur when your case selection is not good. So that's Tarun? What I feel have not seen.
Sure. Tarun, you have any comment?
So same with me, sir. Never had it, but yes, the case selection is the most important thing. So again, the size criteria comes into the picture. So please do not select nodes which are big for a whale. You might end up with having a port site recurrence.
And looking at your presentation, Tarun, you are using a hook, and you use you know, the ligature. With newer tools, I'm using Synchroseal. So what are your comments regarding using a newer tools available nowadays? You know,
so we are still fighting financial issues. So okay. Synchroseal, one use is approximately 50,000 INR, and hook is at 19,000 rupees.
I see.
I also don't use that.
Right. Yeah, because that helps in you know, the vessel sealing. I mean, it's both ways. You know, take care. It's a bipolar energy, and the tip allows you to. Anybody has used ICG, indocyanine green? I have used indocyanine green for the penile cancer. Anyone has experience of that?
I have used it, sir, just for the sake of using it. I mean, we just wanted to see how it looks. It looks okay. I'm not very sure, I mean, how it works, but yes, I mean, you can find out that node which is ICG positive. And
any use of live intraoperative ultrasound? Because initially with the multi-port, I have used you know, the 12mm air seal port, and through that we stick the ultrasound probe to assess the local anatomy. In anybody has any other?
No, sir, I have not used. Probably never required in this surgery.
Right.
The palpation technique is good. I like that everybody use that palpation to see where the anatomic landmark,
Right. And Mutahar, in your single port, the question is they ask, like you took out the specimen, so that is an additional port because you put into catch bag and pull out the specimen?
No, that gel point or the globe, you could put a 12 millimeter
through that,
and then just remove it that way. Yeah.
Right. So the other question is, you all have demonstrated these techniques. Any one of you asked the patient to get a neoadjuvant chemotherapy or checkpoint inhibitor before embarking on doing a lymph node dissection?
Sir, if patient requires neoadjuvant chemotherapy or checkpoint inhibitor, then he's probably having advanced disease. So not so far. If personal experience, chemotherapy is not very successful treatment in neoadjuvant setting. Problem is this: many times they do not respond. The disease actually progresses. So there is a trial, which is an impact trial, is going on, and as far as there is not such guideline for a neoadjuvant chemotherapy in a patient who have non-palpable lymph node or maybe palpable lymph node with up to 2 centimeter, the surgery is the best to offer in first go.
Tarun, any comment?
Same, sir. I agree absolutely 100% with Dr. Ahmed.
So when you are doing this dissection, you go with the zonal anatomy, as whether you are going for the central zone, superior zone, deep zone, or you just go whatever you see in that area. How to figure out these are lymph nodes, not just adipose tissue?
So once you start, So once you start doing it, sir, the idea is to see, even in open surgery, we are never sure what we are taking out. Even on palpation, what you feel might not be a node. So the idea is to take down the entire fibrofatty tissue. So it's sectoral. So you basically start from the apex of the femoral triangle, take the entire tissue which is below the scarpa's fascia, and that goes for the biopsy. Your extent, the anatomical extent has to be proper. The plane has to be proper. You will have the lymph node lead. That will never be a problem.
And most of the time, you can see the lymph nodes. That's not that you can't see.
Yes.
I have seen my young, faculty, rather urologists coming, and when we were doing open lymphadenectomy, they sent the tissue for superficial lymph node packet, and there was no lymph node. So those mistakes could occur in open surgery. So it's not rare to happen in robotic surgery, but you have to be careful. You can dissect them at the table and then send it for frozen. And you can, you have to be in this plane, as Tarun has said.
So one other question, Tarun and Sudhir, both of you are brilliant surgeon and have a vast experience. I was a little bit surprised with your comment that if lymph node is more than 2 centimeters, perhaps you may want to consider open surgery. In my opinion, what you can do with open surgery, if you are doing robotic, you can do a much better job. And I don't go with that idea that if it's less than 2 centimeters, only I got to do a robotic. I do robotic, So why?
So you can do.
No, it's not that question. I'm just asking philosophical, because you can do either way. But the question is, tool allows is better visualization, better control of vessel. You have all demonstrated, and better anatomical delineation of the spaces, zones, all that part. But the question is, why you think? No, I mean there must be some reason. You guys are great, but why open surgery?
Sir, but the reason is mainly the oncological outcome. At 3 centimeters, we feel there will be extranodal disease. In Indian patient, probably you find such patients who have 2.5 centimeter lymph node, which is usual because of the infective etiology and all. But the only concern is about the extranodal disease, which actually offering a minimally invasive approach may actually harm the patient. Not at all. It's technically doable. It's definitely doable. There's no problem with that. Only thing is that concern is about oncological outcome.
No, but that depends on the biologic aggressiveness of the disease itself. But that not because of the technology, means whether you're doing open or minimally invasive. So,
sir, T1.
No, I know.
T2, T3 disease with 3 centimeter lymph node with grade 3, probably I will hold on my robot.
Sure.
In grade 1, grade 2.
Is it because you're worried that it's matted to the skin? Maybe the skin is involved and etc. And that's why you probably not.
You tend to find these surprises, sir. So yes, at times you are lost. At times you enter into the nodes.
But you can definitely do,
Because-
sir. Selective cases, there is no problem.
Technically, that's not an issue, I would say. But yes,
Yeah.
oncologically, I would be more safer if I do it by an open limb.
That's the only concern.
Right. No, I totally agree. It's a dermal infiltration, lymphatic infiltration, all these things can happen. I just wanted to have your idea so people, they're clear in their mind, you know.
Yeah.
Now, the other question I was, you guys think about the dynamic sentinel lymph node dissection in these cases?
Sir, routinely we are not using it. It is there in the literature, DSNBL, and they have shown that 15% of these patients, they may be false negative when they fail. And you know, in penis, once the patient fail in inguinal lymph node, positive inguinal lymph node, it's very difficult to cure them. So because of the robot, we probably can get away with DSNBL.
Yeah, you could do a lot more wide anyhow.
Yeah,
right? So,
yes.
And when you all are doing pelvic lymph node dissection, you are trying to do a ipsilateral or you do a bilateral?
Sir, we prefer to do ipsilateral.
Okay. Tarun?
So I tend to do bilateral because of the cost issues again. I mean, I understand I should not do it, but I mean, to offer it subsequently becomes a very big problem. So I do it bilateral.
SP would be perfect for you.
Probably. Sometime, certainly.
Now, do you three all of all, you have demonstrated brilliant technique. Does your follow-up technique for these cases changes with the kind of surgery you have done? How do you follow these cases?
So it's very standard. So we call them every 3 monthly initially, and the examination, the physical examination is the most important part which we do. That's the groin examination. At times, if the edema is there, which I'm not very sure about the clinical examination, I might offer a ultrasonograph. Beyond that, I do not do much.
No, I'm more talking about oncologic follow-up.
So correct. I mean, this is what we usually do. If there's nothing in the groin, this is what.
Do you do any?
In addition, sir, we prefer to do yearly MRI, and at least for 2 years, 3 monthly follow-up. After that, we delay it for 6 monthly, and after 5 years, probably they get cured. So
and now, suppose patient is a multiple lymph node positive or 2 lymph nodes positive, 3 lymph node positive. Do you consider any adjunctive treatment in these cases?
yes.
Certainly.
Depending on the, if they have 1 or 2 lymph node positive in inguinal lymph node, inguinal area, and pelvic node are negative, because they will have pelvic node lymph node dissection, and there is no E&E extranodal extension, we probably follow them up. But if there is E&E, we'll prefer to give the RT to these patients. But if there is a pelvic lymph node positive also, the patient will go for CT-RT both in our institute.
Yeah, perfect. So I think we covered most of the questions, sentinel lymph node, ICG. Now good. So most of you have already spoken, but I just want to make sure audience, they understand that importance of placement of drain in these cases is very important. And so do you have any cutoff point when we should remove the drain? Sudhir, Tarun, and Mutahar.
Sir, when there's less than 20 ml in 24 hours, I'll remove the drain.
Okay.
Yeah.
See, so 20 to 30 cc's.
I got burned, my first case. I removed the drain early after 3-4 days, or not much there, 50 cc's, nothing. So later on, I had to put a bilateral drain to clear his lymphocytes. So I leave the drain until less than 20 cc. Practically nothing, then I'll take it out. One patient, I had it for 14 days.
Yeah, it happens.
So I think this should be extremely clear to all the audiences, all speakers. They want you to leave a drain unless it goes less than 20 cc or so, because if you don't pull out early, there will be lymphocyte collection, possibility of infection, all those kind of things. So you lose all the advantage what you got through the minimally invasive surgery. So Dr. Bhandari, is there any other question?
I had a comment, and perhaps the catch which Dr. Mutahar Ahmed is not highlighting is the transperitoneal fenestration. And that is the smartest move, because that's kind of windowing we do after transplant lymphocyte or anything. So I think that makes a huge difference. And 2 things, you would never know what is happening inside. Very rarely they show up as clinical signs and it gets absorbed. So drain again has a counterproductive function, may not be in minimally invasive surgery. So my question to all four of you, what is your crystal ball says about level 4 for a condition like inguinal lymph node dissection?
So, I mean, as Dr. Bhandari, still the philosophy of lymph node dissection in cancer itself. I mean, the question is there are 3 goals when you do a lymph node dissection for any cancer. One is the diagnostic yield. So you want to figure it out what's going on. And the therapeutic yield, again, depends on the how many lymph nodes are involved, and then prognostic value, because a lot of we are doing a genomic studies in these lymph nodes and all. So it's contributing towards the molecular biological aspect of these cancer for the future. So I think we do with the criteria of diagnostic, therapeutic, and prognostic value. That is one part. Second, in my personal humble opinion, I have, I get more yield with the what we are doing robotic, but I have not done open. So, and also we are not doing very day in, day out. These are cases are rare in United States. So we get a very selected cases and limited case in a year. So that is that, and certainly there's like say for bladder cancer, we talk at least you should remove 15 to 20 lymph nodes. Same way for the penile cancer. I mean, all of the surgeons, they demonstrated we have got a very good yield. So I think this is a game changer in my opinion for groin dissection. There is no question. If you have a robotic assisted way to go for doing a lymph node dissection in these cases. Tarun?
Absolutely, sir. This is what you perfectly echoed the sentiment. So robotic has certainly changed a lot of procedures, lot of surgeries, but Whale is one surgery which has a robot has dramatic impact upon it, and your yields, your rates of skin complications have come down drastically. So I think this is here to stay, and people should get trained into this particular surgery.
Yeah.
So they.
Yes, sir. I think I said everything. Only thing that I would like to add is lymph node dissection. They are used for not only prognostication, also they are for adjuvant therapy also. So lymph node dissection in CAPN is a must. And we know the open surgery. Historically, there had been the flap necrosis and the problem of healing and the patient coming to you many months. Many times you put a flap also there or skin grafting. But with robotic Whale, those things are avoided. We do not even transpose the sartorius on the vessels. This was routine in open surgery. Though is it palpable or non-palpable node, we will transpose because there is an open wound right onto the vessel. So you have to do this, which is avoided with this. Only thing is problem, the lymphoria and lymphocyl, which I think with the coming from antegrade, like Dr. Ahmed said, we have to prove it. We may pull down sometime momentum also into the inguinal wound. Probably that may reduce. So we have to innovate in that area something. That's the only thing which probably is the problem.
Mutahar?
Yeah, I mean, I'm always optimistic about minimal invasive surgery, right? So I think in the future is coming that we're going to be able to offer much more minimal invasive than what we're doing right now, right? Maybe there will be nanosurgeries. Who knows? I think we're just at the cusp right now. And I know, the surgeons in India, they're always innovative. Look at the stonework. I go to Bangladesh to attend their conference. I always see Indian surgeon coming over and giving talk. Management of stone, mini perk. I heard that 10 years ago in Bangladesh, Indian surgeon talking about it. In US, we're just beginning to talk about mini perk. So in urologic, I think innovation is something is happening, and I'm pretty sure it's going to happen a lot faster, or if not equally in India as well. So this is good. I think it's exciting field, exciting area, time to be in.
Yeah, I think,
one question to you, with your skills of laparoscopy somebody has, you think this procedure is replicable or there is some handicap?
So, Dr. Bhandari, I was just, as we talk about these cancers, so it's not, the bad ordeal for the patient and family, what he has to deal with. And it used to be, if you remember, when we used to do open surgery, it was not a psychological injury to the patient, but to the surgeon also. I do remember in my days, I have to do a S flap, vertical flap, horizontal flap, 2 flaps up and down. And really we used to, next day you go for the round, then you will say, oh, this is Dr. Hemal's patient is still leaking, is still having a lymphocene. And in India, you don't discharge patient unless drain comes out. So I think it has not only changed the psychological ordeal for the surgeon, not only for the patient, but for the surgeon. I think it's the biggest advantage for the surgeon. Dr. Bhandari knows me. I mean, we were doing open surgery. Dr. Bhandari was one who pushed me towards the robotic surgery. And he was the one who was the, behind me that's how I came to the Henry Ford Hospital in 2001. But the reason is this was a game changer. That's how, as Dr. Bhandari was asking, what you are looking in the future crystal ball. So that's the way to think. I mean, we were doing these things laparoscopically, but when we saw this tool, we thought this field can be advanced. And you can see what you heard today. It is a game changer. Now, question whether we can do laparoscopically. Yes, I would say yes, we can do laparoscopically. The balloon dilator, what Dr. Rawal and Dr. Jindal demonstrated, at that point in time, we used to use a red rubber catheter with the finger surgeon glove, and it was just 30 cents. In US, we use a $600 balloon dilator, then we use a blunt tip trocar, another couple of hundred. So think about that. So I mean, still this procedure can be done with the laparoscopic way. You can use a lateral approach. What Tarun has demonstrated is a very good technique for doing that. You create this space. Now, at that point in time, in early 90s or late 90s, those tools were not available. Now we have very good bipolar forceps for the laparoscopy. And also 3D laparoscopy is available. So, but again, if you are increasing the cost, but the biggest advantage of the robotic assistance is that ergonomics, what you get with the Indorus technology, and that is a good advantage in 3D. And if you have 30-degree camera, flip up and down as you like. So these are the couple of, my humble experience, what I can convey.
Only thing I can add, sir, is that I was using laparoscopic veil, and in one day, actually one go, I will do one side only, because by that time I finish, I get tired. And there was no help for me at that time. Now we have a lot of urologists with me. We have a team. So at that time when I was alone, so I will do one day, then bring the patient after 2 days and then do another side.
No,
with the robot, we are doing simultaneously. Well,
I think robotic surgery, definitely. I mean, it doesn't matter which platform you use. I think it's gonna, extend the life of the surgeon, right? Extend their neck, extend their arms, extend their wrist, because you're sitting, you're much more comfortable, and you're able to do lot finer surgery.
Sudhir, one question to you, that you have experience of different new robotic platforms.
I knew this question is coming to me. I know, sir. Yeah. Please go ahead.
I don't want to pit one against other, because they'll have their learning curves. Yeah. Do you sense that it would be replicable, or there would be some handicaps when you are talking in terms of Da Vinci versus other systems?
Sir, I'm sure 100% it will be replicable.
Okay.
Yeah.
I think it's a matter of just
why I say is, Dr. Ahmed, just why I say is that Da Vinci is around 23, 22 years evolved technology. And these new robots which are coming in the market, they are very new, young. And then the way they are improving, because I personally, I'm involved in one robot, like anything. And we have Medtronic's Hugo also. So the way these things, they are evolving, definitely you will be doing everything with these robots. And then there are many things with the idea which are going on in their workshop and all. They will be, disruptive. They will be changing the market completely.
Yeah, I absolutely agree with Sudhir. I mean, those who came to AUA meeting this year in Chicago, you saw the single port robot from Chinese origin. Yeah, so I mean,
right bang opposite to intuitive stall.
But looking at all this, Dr. Bhandari, we feel I should start my residency now with great tools. We have suffered doing open surgery. We have suffered doing laparoscopic surgery. So robotic assistance, I feel that it's a game changer for the surgeon's life, surgeon's, precision, how you do that. I mean, it's a really very, very good advantage, not only to the patient, but to the surgeons.
Thank you very much. I think it was a wonderful experience listening to you guys and revising old concepts.
Thank you, sir.
Thank you.
All right, we'd like to thank all the listeners all across the world who are joined on this, our seminar live. And thank you for sending your questions to all our speakers, and you heard all the answers from them. And this seminar will be available live for you all to, view in the future. And everybody, and if you have any question, please send to them. And also the VAT Equity Foundation is requesting you all to submit your videos. You have done, I know all of you are doing fantastic job, what excellent videos, techniques. So you can send for the KS International Innovation Award. And the last date for submission is June 15th, and you can go online and submit. And, this is a very, very fair competition, and it's a very, very good. I had the opportunity to watch last year. It was a fantastic program. So we would request you all to join for this and also submit your videos. And with this, I would like to thank you all.
Yeah, I think
Thank you, sir.
I will first request these panelists that each one of them have wonderful material and ready videos. So I think please don't hesitate and dump them down to the portal, because we would like to have really classy techniques and take it to the next level. So that is my appeal to the presenters, in addition to thank you, Ashok. Dave, would you like to say anything and close this?
I think you gentlemen have said it all. It's been a very fascinating presentation. I think the group discussion was amazing. There's so much knowledge from you giants of the field. And I'd like to say thank you once again, and we'll see you at another webinar.